Very nice. Sorry for all these troubles, and we are delayed. So inshallah, we are going to start today about the pulmonary function test, and we'll have this skill lab. We'll be doing on Tuesday from 1 p.m. Right, in 4 groups. So in the male side, I'll be taking this lab. In the female side, I'm not sure who is going to take it. So this is the discussion about those pulmonary function test. So what is pulmonary function test? So what are the tests done to know the lung functions? So we can so stop, stay there, stay there, stay there, stay up. Yeah. So there are 4 tests we could do to test the function, lung function. One is the spirometry. Spirometry, peak flow meter, diffusing lung capacity, and arterial blood gases. These 4 things. But in the lab on Tuesday, inshallah, we'll be doing only these top two, the spirometry and the peak flow meter. Okay, go up. Slide number 2, 3. Yeah. So what are the indication for doing the lung function test? So to detect the presence or absence of lung disease, quantify the extent of known disease on the lung function. So known disease could be the asthma or COPD. What is COPD? Anybody knows COPD?
Chronic obstructive pulmonary disease.
Chronic obstructive pulmonary disease. Yes, chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease is, can you give me an example of those disease? COPD?
Emphysema, chronic bronchitis.
Okay, emphysema, chronic bronchitis. Okay, so these are called the COPD, asthma. So we can quantify the extent of the disease. Number 3 is the assessment of occupational hazard. Occupational hazards. What is occupational hazard? What kind of occupation can cause the lung disease? Any idea?
Toxins.
Asbestos? Asbestos, yeah. Asbestosis, silicosis, berylosis. So like people, those who are working in the asbestos factory or doing the construction work with the sand blasting, all are called the occupational hazard. Okay. Number 4, evaluation of beneficial or negative effect of the therapy. To evaluate. So you are treating a patient with asthma with the bronchodilators. So now you want to evaluate if this treatment is beneficial or have any adverse effect or negative effect. Number 5, preoperative evaluation for surgical procedures. So for example, if somebody need the lung resection or any abdominal surgery, so before those operation, we need to do this pulmonary function test. Number 6 is the evaluation of disability or impairment. So if a patient come to you and say, doctor, I have the lung fibrosis and I need the disability letter from you so I can get the disability benefits. So to evaluate those, you will need to do this pulmonary function test. Okay, please share the slide. So those are the indication, and here these are the contraindication. So we will not do the test. Contraindication. If the patient is non-cooperative, patient does not listen to your command. Number 2, lack of coordination. So you are telling the patient to take a deep breath and breathe out. He's not coordinating with you. So we cannot do the test. Severe dyspnea. If the patient has severe difficulty in breathing. Number 4, very young or very old patient, like the 4-year-old boy. He will not understand what you are saying. Or very old patient. Okay, number 5, patient with infectious disease. For example, pulmonary tuberculosis. We cannot do this pulmonary function test. And hemoptysis of unknown origin. Hemoptysis. Okay, so bleeding with the cough. All right, so there are more contraindication here in this page. Number 7, pneumothorax. Pneumothorax. Already you know this case. Case number 1 was pneumothorax, right? And number 8, unstable cardiovascular status. Recent myocardial infarction or pulmonary embolism. If patient has the recent MI, we cannot do the pulmonary function test. Any thoracic, abdominal, or cerebral aneurysm. What is aneurysm? Any idea?
Weakening of the arterial walls.
Yes, very good. Weakening of the arterial wall, and arterial wall become dilated. So if there is a condition like this in the abdomen or thoracic or cerebral arteries, we cannot do this pulmonary function test. Recent eye surgery and recent thoracic or abdominal surgery. So all these are contraindication for doing the pulmonary function test. So when patient come to you for the lung function test, you have to ask for this. If he has any of these condition, we cannot do the pulmonary function test. So we know the indication, we know the contraindication. Is it clear to everyone?
Yes.
Okay, thank you. Go to the next one. So now how do we do this test? What is the patient positioning? So when the patient come, so he'll be sitting up and straight. So you will give him a high chair, he will be sitting up and straight. The feet will be flat on the floor with the leg uncrossed. So leg should not be crossed from right to left or left to right. It has to be straight. Loosening of the tight fitting clothing. So if he has a tight shirt, it has to be loosed. And denture normally left in. Okay, so these are the patient positioning. Okay, for the infection control, what we do, our hand must be washed. So if we are doing multiple patients, so between the patient, when we change the patient on patient to the next one, we have to wash the hand and dispose the mouthpiece after every test. So every test will have a new mouthpiece. Okay, next one. Okay, spirometry. So this is the test we do. So what is spirometry? Actually, after finishing this lecture, I will show you some of the video how these tests are done. So on Tuesday when you do this, so you will have easy understanding what is done. So similarly, Rami, I will send you some of the link of the video. Okay, so you will share those as well.
Okay, doctor.
Okay, 1 second. Let me find the videos and. Mhm. Okay, so I'll do it. Let's finish this first. So spirometry. So what is spirometry? Spirometry, it is to measure the flow and volume of air. So two things, the flow and the volume of the air that is entering and leaving the lung as a function of time. Time in second, like in 1 second, 2 second, 3 second, 4 second, up to 6 second. How much air is entering and leaving the lung. So we'll measure with this machine, small machine, we'll do it inshallah, on the lab. So you'll see it. So this is called the spirometry. Okay, go up. So performance of the FVC maneuver. What is FVC? FVC is the forced vital capacity. How we do this? So there is a nose clip and mouthpiece. So we'll tell the patient, inhale as much as possible. Okay, he will inhale the air as much as possible. Put the mouthpiece in the mouth, okay, and exhale as hard and as fast as possible through the mouth. Exhale through the mouth, so our nose will be blocked. So nose will be blocked, only exhaling through the mouth, okay. And then we will encourage the patient and we'll tell him, okay, take a deep breath, take it, and then we'll encourage him to exhale as hard and as fast as possible. Okay, that's how we'll be doing the spirometry. Okay, next one. So here on the right side, you see there are two graphs. It is showing the tracing of the flow volume. So so here on the top paragraph, you see there is a two bump. So, and in the bottom paragraph, you see there is a going up and there is a gradually going up straight line. So, so these two line is showing us how long this exhale is going. So exhale is for about 6 seconds. You see at the bottom of the slide, exhale is in for 6 seconds. So he'll be taking a deep breath and then breathe out for 6 seconds. Okay, go up. And then when we are doing this, we will do it 3 times. Repeated minimum 3 times. And from these 3 times, it has to be reproducible. How we know it is reproducible? In order to meet the reproducibility criteria, all 3 FEV on measurement, FEV, that is the forced expiratory volume in 1 second, and all 3 FVC measurement must be within 200 milliliter of each other. So if on FVC is 5 liter and the next one is 6 liter and the third one is 7 liter, this is not reproducible. It has to be within 200 milliliter. So if one is 5 liter, the next one could be 5.2 liter, the third one could be 4.8 liter. That's about it. So it has to be within 200 milliliter of range. If any of this condition is not met, the test has failed to meet the reproducibility criteria. Okay, is it okay? Is it clear? All right, so reproducibility we know. So go to the next one. So lung volume. So lung volume, so there are 4 types of lung volume and 4 types of lung capacity. So capacity we can calculate from the volumes. 4 lung volumes. So what are the lung volumes? So you see, so go to the next page, so it will be more clear. So here it is shown as a whole. Next slide, please. Okay. So this is one of the volume. Okay. Tidal volume, TV. You see in the middle, tidal volume. What is tidal volume? Volume of air inspired and expired during normal quiet breathing. So like you are sitting and listening to me in your room. So now still we are breathing, right? Breathing is going on. So inspiration and expiration during this normal quiet breathing, the volume of air that goes into our lung is called the Tidal volume. It's about 500 ml. 500 ml. Okay, tidal volume. Next one. Next one is IRV. What is IRV? Inspiratory reserve volume. This top one, IRV, the top paragraph. The maximum amount of air that can be inhaled from the resting end of the inspiratory level. Maximum amount of air that we can inhale from the resting amount of inspiratory level. Okay. Third one is the ERV. ERV, the bottom one. ERV is the maximum amount of air that can be exhaled from the resting end of the expiratory level. ERV. Okay, next one. And residual volume. The volume of air remaining in the lung at the end of maximum expiration. So how many volumes we got? 4 volumes. Tidal volume, IRV, ERV, and residual volume. These 4 volume. Now go to the next one. So these are the 4 volume. So we can calculate now the capacities. There are also 4 capacity. 4 volume, 4 capacity. So the first one is the vital capacity. What is vital capacity? VC. Volume of air that can be exhaled from the lung after a maximum inspiration. So you take a deep breath and you breathe out. So this volume is called the vital capacity. So vital capacity that can be exhaled forcefully from the TLC, total lung capacity. Okay, so there is a forced vital capacity, FVC. There is a slow vital capacity, SVC. So what is forced vital capacity? When you take the forcefully, inhale and exhale. And slow vital capacity, when vital capacity is exhaled slowly, very slowly. That is called the slow vital capacity. Okay, so vital capacity is the combination of 3 volume, IRV, TV, and ERV. So this vital capacity thing is very important because our spirometry is based on this vital capacity. Is there any question about this? About the vital capacity? How many types of vital
Can
capacity?
you repeat it?
Yeah, how many types of vital capacity we know? 2 types.
2.
Okay. One is forced vital capacity, other is
Slow vital.
slow vital capacity. What is the difference between these two? What is forced, what is slow? Is written here in the slide.
Forced exhaled or slow exhaled?
Exhaled forcefully. That is the forced vital capacity. And the slow vital capacity?
Slow exhaled.
Exhaled slowly. Okay. What is exhale? What does exhale mean?
Breathe out.
Breathe out.
Breathing out.
Okay, breathe out. Okay, so breathe in, breathe out. So in the forced FVC, you breathe out forcefully. In the SVC, you breathe out slowly. Is it okay?
Yes.
Forced vital capacity and slow vital capacity. We need to know this. And what is vital capacity? So vital capacity is the combination of tidal volume plus IRV plus ERV. Okay. Okay. Next one, please. Okay. So after the vital capacity, the next one is inspiratory capacity. IC. Inspiratory capacity. What is IC or inspiratory capacity? Maximum amount of air that can be inhaled from the resting expiratory level. Maximum amount of air that can be inhaled, that we breathe in from the resting expiratory level. That is IC. IC is the combination of tidal volume plus IRV. Okay. Next one, functional residual capacity, FRC. What is FRC? The volume of air remaining in the lung at the end of expiratory level. So ERV plus RV is the FRC. Okay. And the last one is our total lung capacity, the volume of air in the lung at the end of maximum inspiration. So total lung capacity. What is the total lung capacity? Anybody knows how much volume our lung can hold?
6,000 milliliter or 6 liter.
6 liter, yeah. So total lung capacity is 6 liter. Our we have two lungs, so two lung can contain about 6 liter of air. It could be more or less depending on the size. If somebody is very tall, he might have 6.5 liter or 7 liter. If somebody is very short, could be 5 liter. So, but on average is 6 liter is the total lung capacity. Okay, so we got 4 volume, 4 capacity. Is it okay for everybody?
Yes, doctor.
Okay.
Yes.
Okay, so next one, volume and capacities which cannot be measured by this parameter. We cannot measure the residual volume. We cannot measure the functional residual capacity. We cannot measure total lung capacity. These three things we cannot measure with this spirometry. So residual volume, what is residual volume and what is the significance of it? So residual volume that remain in the lung all the time. And it's about 1200 milliliter of air, 1200 ml of air. Why we need this? Why we need the residual volume?
For emergency?
What kind of emergency?
Emphysema, maybe.
No, actually, there's a physiological function. The function is this amount of air we need all the time because the gas exchange, right, is happening between the alveoli and the capillaries all the time. So as we are breathing in and breathing out, there is always some air inside our alveoli that is exchanging the gas exchange, that is doing the gas exchange between the alveoli and the capillaries. Is it okay? Is it clear? Okay. Next one. Yeah. You see, forced expiratory volume in on second or in the first second is called the FEV on. Like in today's case number 3 today, you heard about this thing, right? FEV on and FVC. So pay attention very carefully. So what is this? What is FEV on? FEV on, as you see in the picture, the volume of air that is expired in the first second from the beginning of a FVC maneuver. So normal people can exhale more than 75 to 80% of the FVC in the first second. In the first second, you see, so in this picture, in this figure, so what is the FVC? Who can tell? What is the FVC here? This is the FEV1, yeah. FEV1 is about, let's say 3.75, right? 3.75 liter. FBC, how much? 4 point, let's say 4.5. Yeah, so if you do the ratio, what is the ratio? Maybe 75 to 80%. Yeah, 80%. So this is normal. In normal people, the ratio about 75 to 80 is the normal. This is the FEV on second. In 2 seconds, if you do the calculation, it will be about 95% ratio. In 3 seconds, the ratio will be 97%. Okay, so FEV on over FBC, this is a ratio, and this ratio for the normal people is 75 to 80%. You have to remember this. If you know the normal, then we will know the abnormal. Okay, any questions from here? Okay, next one. Here you see. So normally the whole value of FBC is expelled in 4 to 6 seconds, as you see. 75 to 80% in 1 second. FEV2, 95%. FEV3, 97%. So now on the right hand side, the picture as you see, so the top on in the normal people, and in the middle on in the restrictive lung disease. Yes, restrictive lung disease. And the bottom on is the obstructive lung disease. So in the bottom on, FEV on over FBC, the ratio, and in the restrictive one, FEV on over FBC ratio, what do you think? The ratio in case of obstructive lung disease, what will be the ratio?
Maybe 50%,
Maybe
40%,
yeah, 40-50%. Okay, very good. How about the restrictive lung disease?
80%.
60.
So yes, very good. So in restrictive lung disease, the ratio looks like the normal people. Ratio does not change that much. But in the obstructive lung disease, the ratio is reduced because FEV on is reduced. So forced expiratory volume on the first second, the expiration. So here is the question. In the obstructive lung disease, what is the problem?
Damage
There
in
is-
the
Problem in the expiration, right?
Yes.
Obstruction in the airway, so the person cannot exhale. So obstruction in the airway during breathing out, not breathing in. Okay, very good. Got the next one. This is the loop. When you do the spirometry, you will see this loop. So left hand side, as you see FEV on and FBC. On the right hand side, there is two things. This is called the flow volume loop. Flow volume loop. So the lower portion is the inspiration and the top is the expiration. So here you can see the peak expiratory flow rate, PEFR, but PEFR we have another machine, so we can do in both way, in the spirometry and also with the PEF machine. Okay, next one. Here you go. So here in the flow volume loop, it is showing three conditions. Number A is in the normal. Number B, obstructive lung disease. Number C, restrictive lung disease. Okay, so now between the B and C, what is the difference? What do you see?
B in expiration only, and I think C, all the whole process is reduced.
Yes. So B is the obstructive lung disease. So in the obstructive lung disease, the problem is exhalation,
Yes.
expiration. Okay. And in the restrictive lung disease, both inspiration and expiration
Inhalation.
is reduced.
inspiration.
Both are reduced. Very good. Okay. Next one. Okay. So this is the maximum breathing capacity or maximum voluntary ventilation. What is this? This is the maximum volume of air that can be breathed per minute with voluntary effort, voluntarily. Like consciously, I am breathing in and out. Okay. What is the procedure? How do you do this? So we'll ask the subject to breathe as fast as possible and as deep as possible for 15 seconds. So we'll ask the person to breathe fast and deep for 15 seconds, then multiply by 4. So we'll get the volume per minute. So normally what is the normal volume? 60 to 82 on 60 liter in male or 62 on 20 liter in female. So this is a test for the entire respiratory system. So this is mainly we are doing in 1 minute, not in second. This is the main difference here. Okay. Okay, so this on PEFR, peak expiratory flow rate. You have heard this word during our second case, right? Peak expiratory flow. So what is this? The device, as you see on the right hand side picture on the top, this small device. So in this device, how do we do? We can attain the maximum flow rate during force vital capacity maneuver. It is usually recorded in a liter per second. Okay, but also you can convert into liter per minute. So how do we do this? So it is also personalized, like it depends on the size of the patient, height, body weight, all these things it determine. So we attach a mouthpiece to the device and then we ask the patient to breathe into that device. Okay, go to the next one. So how we do this? So create a tight lip seal around the mouthpiece. Take a deep breath and exhale as quickly and as forcibly as possible. And repeat it 3 times. Highest recording is taken. Okay. So what do you do? So when I give you the device, it's a very small device, you can see it. We will attach a new mouthpiece. It's like a small mouthpiece. So we put that mouthpiece into our mouth and then we take a deep breath as quickly as possible and then we tell the person to exhale as quickly and as forcibly possible. Repeat this thing 3 times and we take the highest reading. Then we dispose the mouthpiece and that's how it is done. So if the patient is on a bronchodilator, then the reading should be taken before receiving their medication and after 5 minutes. So what is bronchodilators? Bronchodilators. Today, in your case, you had this bronchodilator thing. Why?
Salbutamol.
Yeah, so why we use the bronchodilator? To dilate the bronchus. To dilate the airways, yeah, to dilate the bronchus, to dilate the airways. So bronchodilator, there are 2 types, short acting and long acting. Like salbutamol is a short acting. Okay, all right, good. Go to the next one. So what is the advantage of this peak flow meter? This small device, portable, so we can keep in our pocket and do it anytime. And it is used very easily. So it can be done in an outpatient setting or in a bedside clinic, okay? And there are also disadvantages because sometimes the reading is very inaccurate or it is effort dependent. You are not putting too much effort, the reading will be low than the normal, okay? All right, go to the next one. Here you see, in this picture on the right side, it is showing the difference between the men and women. On the left side, you can see the peak flow volume in the liter per minute, and also depending on the age. So peak flow is peak when you are around 30 to 40 years of age, and then it declines in both men and women. Okay, so now in young healthy adult, peak flow rate is 500 to 700 liter per minute, as you see from the figure. Also, its value is limited because it is effort dependent. It measures large airway obstruction, not the smaller air, not the terminal bronchioles, only the larger airways like the bronchi, primary, secondary, tertiary, all those, but not the smaller bronchioles. Okay, go to the next one. So what are the clinical application of the peak flow meter? How we use this? Used to monitor the asthmatic patient at home. If the patient has the asthma, you are a doctor and you have the asthmatic patient, so you will give this small device to take the measurement at home. So, so when the person has no asthma attack, then he will do this test and then he will set the standard. For example, 500 liter per minute, that is standard. Now, when he will be having the asthma attack, so daily monitoring of the PF can provide early detection of asthmatic episode. So now this morning he did this PF measurement and he saw it is like 400. So he can predict that he might have asthma attack coming. So he can prepare himself by taking more bronchodilators or talking to the doctors how to do it. Okay. So it will provide the objective criteria for the treatment. So with this we can increase or decrease the dose of the bronchodilators, and also it can determine the specific trigger, like what kind of allergen or any workplace exposure that can cause the symptoms of the asthma. Okay. All right, so this was about the lecture. So in this lecture, in a summary, so what we did, we mainly learned about the two techniques, spirometry and the peak expiratory flow rate. So any questions about this?
Doctor,
Yes.
what does it mean by BAF monitoring provide objective criteria for treatment?
Yes. Objective criteria. So you give this small device to the patient to take home. For example, your patient has asthma. Okay. Now he is doing this monitoring every day in the morning. So he keep the recording of every day. So for example, Yamulahad, his recording is 500 liter per minute. Yamulutnin, again 500. Yamutalata, it become 400. Yamur Rabu, it become 350. So what it is showing? If you get this kind of
Decreasing.
reading, so his expiratory flow is decreasing. So what does it mean? That means you give him the treatment, like he's asthma patient, right? So what kind of treatment you gave him? Like from your case, from case number 2 and 3, what do you know? So you gave him bronchodilator or inhaled corticosteroid, right? probably you tell him to take one puff in the morning. So maybe objective criteria means maybe the treatment that you gave him, the dose is not enough. That's why he is having this. He's not having this proper reading, because his standard reading should be 500, but it is getting 400, 350. So he is having he will have the asthma attack in couple of days. So then when he call you and say, doctor, I am having this kind of reading. So what you will do? You will increase the dose of the bronchodilators. So that means this is the objective. It is objectify what you need to do with this. Okay.
Okay, doctor, I have another question.
Yeah.
Can you repeat the technique of peak expiratory flow rate?
Peak expiratory flow rate. Okay.
Technique.
Okay. So let me yeah, I'm going to show you a video that will be better, because if I tell you now, let me send you this video link to 1 second. Okay. One second. Okay, Rami.
Yes, doctor.
Okay, I sent you some of the video links to your WhatsApp. You saw that?
Yes, I received it.
Okay, so please open this on the PEFR.
Okay.
1, 2, 3, number 4 from the top. Yeah, number 4. Yeah. There is no sound.
Good morning, my name's Andrew. I'm one of the final year medical students. Could I just confirm your name and age, please?
I'm Simon and I'm 24.
Nice to meet you, Simon. Today I've been asked to take something called a peak flow measurement. This will just involve breathing out into this peak flow meter on the table. Would that be okay?
Yeah, that's fine.
It'll just help us assess how well your asthma is controlled at the moment.
Okay.
Okay, Simon, in terms of setting up the equipment, the important aspects are to ensure that the mouthpiece is inserted into the peak flow meter, and to ensure that the dial is set to 0. Now that you've got your equipment set up, Simon, there's some important aspects of the technique to remember. These are to ensure that you're sat up nice and straight, to take a nice deep breath in as far as you can, to ensure that your lips are sealed around the mouthpiece, and to breathe out as hard and as fast as you can. Okay?
Okay.
I'm now going to demonstrate. You then need to look at the reading you get on the peak flow meter. Okay? Was that all quite clear?
I think so, yeah.
Brilliant. Would you like to just repeat to me what you've learned so far?
Sure, okay. So I need to put my own mouthpiece in, set the dial back to 0, and then sit up nice and straight, and then take a nice deep breath in as far as I can, and then breathe out as hard and fast as I can as well.
That sounds perfect, yeah.
Okay.
It's now time for you to have a go.
All right.
That's a really good score of 700. To finish, we just need to take another 2 readings. We'll take the best of all 3 readings and record it in your peak flow diary. Okay. Thank you very much.
All right. So tell me. So is it okay? The peak flow?
Yes.
So it's very easy. It's a small device. You just put a new mouthpiece for your own. Take a deep breath and then breathe out and do this 3 times and take the best reading. This is your peak flow rate. Okay. Any questions about this? Okay. Rami, show us another video. Show this flow volume loop interpretation. Just below the this one.
هربل اسنسز بالالوفيرا الطبيعيه المركزه بيعطي شعرك ترطيب عميق بيدوم 72 ساعه.
Okay, here we're going to talk about the flow volume loops for obstructive lung disease and restrictive lung disease. So just to explain what's going on in this curve over here, so on the x-axis, we're going to have volume of air in liters. And on the y-axis, we're going to have flow of air in liters per second. What's going on top of the curve is expiration, and on the bottom of the curve is inspiration. Okay, so let's begin. So let's take a look at some important values. So let's take the normal case. And let's say a person tries to breathe in and breathe out. So they breathe in. So they breathed in their full capacity. This is known as the total lung capacity over here. How much their lung is capable of containing. Total lung capacity. And then they breathe out. We see that there's still a little bit of air left in their lung over here. This amount of air over here that's still left in their lung after they fully expire is known as the residual volume. So if you take a look over here, this guy's going to represent obstructive lung disease. Obstructive lung disease includes things like emphysema and chronic bronchitis, often associated with smoking. And thus we have this guy over here who's smoking. And what we note is that the entire curve shifts to the left. And that's because there is an increase in residual volume due to the air trapping. And there's also an increase in total lung capacity. The total lung capacity goes from normal, which is at 6, to larger than 8 liters. We also note the characteristic kink over here, and that's due to the obstruction during inspiration. Over here, we note restrictive lung disease. This includes lots of things, including things like pneumoconiosis, berylliosis, silicosis, associated with lots of workers. People who work in the manufacturing business with mining. And thus we have this worker over here to remind us of that. And here the curve shifts to the right. Due to the restriction, for example, due to fibrosis and loss of compliance, everything is reduced. Residual volume is reduced. Total lung capacity is reduced. Every value is reduced. And that's why the curve shifts to the right. Okay, so I hope this video made things memorable and fun.
Okay, so about this video, so a little difference between the restrictive and obstructive lung disease. Is it clear there?
Yes.
In the obstructive lung disease, what happens to your total lung volume and residual volume? in the obstructive lung disease?
Reduced.
In the obstructive lung disease, your total lung capacity increase because go back to that video. Go back to that video a little bit. Yeah. So because I want you to understand this. Yeah. The seat here. The seat here. Yeah. Yeah. No, just show it there. Yeah. Just show it there. Yeah. So obstructive and the restrictive. So in the normal, from this figure, what is the total lung capacity? From this picture. From
6 liter.
6 liter. Very good. In the normal, what is the residual volume? Zero to 2.
liters?
So 2 liter. 2 liter. This is the normal. Okay. In the obstructive lung disease, what is the total lung capacity?
8.
8 liter. So in the obstructive lung disease, the total lung capacity is increased, right? Okay. In the obstructive lung disease, what is the residual volume?
4.
4 liters. Yeah. So is this clear now? Similarly, in the restrictive lung disease, what happens to the total lung capacity? What is the total lung capacity in restrictive lung disease? Less than 4. Less than 4. And the residual volume? About 1 liter. So everything is reduced here. So if you remember this graph, you will always answer the difference between obstructive and restrictive lung disease. Any questions? Okay.
Doctor,
We'll see the
total
last
lung
bit.
capacity, is it the same?
No. Lung capacity is not the same. Because in
Not,
restrictive, in restrictive lung disease, your lung is restricted. Your lung is smaller, restricted, it cannot expand. So your volume is smaller. In obstructive lung disease, from the lung, the air cannot go out. So the air is trapped inside the lung. So that's why your lung volume is increased. Okay? You have to think what is happening. What is happening in the obstruction, what is happening in the restriction. So restrictive lung disease, it could be due to the lung problem itself, or it could be due to muscle of respiration, neuromuscular disease, all these things. Okay. Any questions? Okay. We'll show you another video, then we can stop. Rami, please go back. Show us the top one.
Spirometry is a common test for lung function. It is used to diagnose asthma, COPD, pulmonary fibrosis, and other lung diseases. It can also be a helpful tool to monitor disease progression and evaluate effectiveness of a treatment plan. A tube-like device called a spirometer is used to capture and record air volumes and breathing speed. A spirometry test typically reports 4 respiratory volumes: tidal volume, TV, the amount of air inhaled or exhaled during normal, quiet breathing without effort; inspiratory reserve volume, IRV, the amount of air that can be inhaled with maximum effort after a quiet inhalation; expiratory reserve volume, ERV, the amount of air that can be exhaled with maximum effort after a quiet exhalation; residual volume, RV, the amount of air remaining in the lungs after a maximum exhalation. These volumes are used to calculate other parameters called respiratory capacities. Inspiratory capacity, IC, the maximum amount of air that can be inhaled after a quiet exhalation. Functional residual capacity, FRC, the amount of air remaining in the lungs after a quiet exhalation. Total lung capacity, TLC, and vital capacity, VC, the amount of air that can be exhaled with maximum effort after a maximum inhalation. This is basically the volume of the deepest breath the lungs can possibly handle and is an important indicator of pulmonary function, as well as strength of respiratory muscles. Vital capacity can be measured as slow vital capacity during slow, relaxed breathing, or as forced vital capacity, FVC, when the patient is asked to breathe out as hard and fast as possible. While there is little or no difference between these two values in healthy individuals, people with difficulty exhaling usually show significantly lower FVC. Another important parameter obtained during forced spirometry is the forced expiratory volume, FEV1, the amount of air that is exhaled during the first second of forceful exhalation, after a full inhalation. FEV1 is used to calculate the percentage of air that is expelled during the first second. This FEV1 over FVC ratio inversely reflects the resistance to expiratory airflow. In healthy people, it is around 70 to 85%. A smaller number means increased lung resistance. Spirometry is useful in differentiating between restrictive and obstructive pulmonary diseases. Restrictive lung diseases can be inspiratory or expiratory. Inspiratory restrictive are conditions in which lung compliance is reduced, limiting lung expansion when inhaling. This can happen either because the lungs become stiff as a result of scarring or fibrosis within lung tissues, or the respiratory muscles are too weak to inflate the lungs. Expiratory restrictive is when exhalation volume is limited due to weakness of accessory muscles involved in deep exhalation. Restrictive lung diseases are associated with decreased lung volumes, or total lung capacity, TLC. Obstructive lung diseases, such as asthma or COPD, on the other hand, show a normal or somewhat increased total lung capacity, TLC. This is because the obstruction increases lung resistance, making breathing out harder and slower, and this results in increased residual lung volume. Vital capacity remains normal during quiet breathing, but when breathing rapidly, a higher pressure is required to overcome the increased resistance, and forced vital capacity is reduced. A more reliable indicator of obstructive lung disease, however, is the lower percentage of air that is exhaled during the first second of forceful exhalation.
All right, so any questions from this video? It was nicely explaining about the differences between restrictive and obstructive and what is spirometry and how to do it. So any questions from today's lecture? So it's easy, inshallah. So in the lab tomorrow, not tomorrow, on Tuesday, right? Rami, it is tomorrow, Tuesday at 1 o'clock, right? We have 4 groups.
Yes, each group 1 hour.
Each group 1 hour. Yeah, maybe we'll not need 1 hour. So depending. So if we finish early, it's okay. So we'll be having only 2 tests because we talked about everything now. So just when you come to the lab on Tuesday, inshallah, so we'll do the spirometry and peak flow meter, these 2 things for each group. So spirometry takes about like 3-4 minutes to do, and peak flow, as you have seen, like on 2 minutes for a student. So inshallah we'll do it. So any questions, anything you don't understand, you can ask me any questions. Is everybody okay?
Thank you, doctor. Yeah, it's okay.
Yeah, so if it is okay, then inshallah I'll see you on Tuesday. And if you have any questions,